Yeah, we are live now. So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar. And today we are back with our series MedMocha Meetup Season 1, Session 18. And today it's a mixed bag webinar consisting of two eminent speakers. So let me introduce the organizer of this webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIOG, AMRCOG, ART Singapore. Ma'am is consultant obstetrician, gynecologist, infertility specialist, sexologist, and cosmetologist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. Ma'am is the top 50 influential doctors on social media. So I welcome you, ma'am, and I hand over the session to you.
Yeah, thank you, Sahiti. And thank you, Shield Pharma, for providing the platform for this program from the constant 3 years. And still, by the grace of my Mata Rani blessings, still the program is rocking well, not only in India, but all across the geography. So today we are having with me my two dear friends, Dr. Atmik Jain and Dr. Mitali Srivastav. Today, friends, our focus of the webinars is on the related to the sexual problems. So, as we all know, taking the history is also very important in these patients. And with Dr. Mitali, we are going to discuss about the female sexual dysfunction. And with Dr. Atmik has joined all the way from the Indore. Warm welcome, dear Atmik and Dr. Mitali.
Thank you, ma'am.
So,
Thank you so much.
yeah. So, friends, as we
Thank
all
you.
know, the related to masturbation, Dr. Atmik is going to discuss with us related to about the with the masturbation. What are the myths and facts? Earlier, we are seeing the patients who are coming to us for the queries are only the males. But now these days, we are seeing on our OPD, a lot of girls are also coming related to having lot of queries related to masturbation. There are so many myths in their minds. Yes, the masturbation causes the weakness, or the males are coming that it causes the erectile dysfunction. How many times in a day they can do? Like this, there are so many questions they are having. So before I hand over the dais to Dr. Atmik, may I request Sahiti, please introduce Dr.
Sure.
Atmik.
Yes. It's my privilege to introduce Dr. Atmik Jain. Sir has done MBBS from R.D. Gardi Medical College, Ujjain, Madhya Pradesh. Fellowship in Psychosexual Medicine, JSS Medical College, Mysuru. European Society of Sexual Medicine School, trained in ESSM School. Heading Department of Sexual Health as sex counselor and therapist from Motherhood Hospital, Indore. Member of editorial board of magazine issued by Council of Sex Education and Parenthood International, News and Views. Working as a sex counselor and therapist at Arihant Hospital, Indore. Sir has been affiliated to ISSM, ESSM, ESHRE, SASSM, CSCPI, and ISAR. I welcome you, sir.
Thank you. Thank you so much, ma'am, for this warm welcome.
Warm welcome, dear Atmik. So, meanwhile, the doctors will start joining. We are able to see some friends have joined from Africa, and Dr. D. Hartman is also there. So,
Yeah.
friends will start joining in the YouTube also. So, yeah, we will hand over the dais to you. Yes.
Okay, ma'am. Thank you. Thank you so much, ma'am, for this opportunity. And I would like to thank Mitali, ma'am, also for this collaboration. And we actually joined hands for this great venture and actually spreading awareness for all the doctors and the non-medico, our friends who are listening to us. And the topic is very interesting and very controversial. That is masturbation myths and misconceptions. Before starting the topic, I would like to share a small incident which happened recently. Recently, I was called in a school in my town, and I was asked to give a lecture, give a presentation on adolescent development and their social obligations, responsibilities, and their roles. So I asked them not to raise their hands or to stand up and ask questions, as they are very much, they feel very much shy. So I asked them to write small questions on piece of paper and just pass it on to me. So majority of the questions were related to masturbation and their penis size and the side effects of masturbation and the frequency. And to my surprise, the thing was it was not related to masturbation, but how the majority of the students are concerned about their masturbatory habits, their frequency, and what they are going to suffer. And the and they how they wrote the questions, how they framed the questions were so accurate. I thought I was interacting with some medical students.
Oh,
Yeah, so that was very much surprising and that was very much shocking for me. The another doctor was giving a presentation for the females of ninth standard and 10th standard, and to the principal and the other teachers as well. Okay,
okay.
so this shows that how important is sex education, and the age is not defined. In the era of internet, the age is not defined because the children are very much exposed to each and everything, and to what extent we don't know.
Very true. Very true.
Yes, ma'am.
With the this great easiness for the internet, for the social media, so a lot of myths, they all are what the videos they see, what the reels they see, they found that all is okay. So the motto of this program, what I started 3 years back, is to increase the knowledge amongst all. So what the problem we have faced in the starting of our career, now in this era, as the internet is so widely available, and we
Yeah.
can share our knowledge with each and everyone. Yes, over to you. Yeah.
Thank you, ma'am. Thank you so much. So we start the topic for today. It's
Yes.
masturbation myths and facts. Okay, so why we need to talk about sex? Why there is a need to talk? First, to clear our doubts. There are a lot of doubts. Second, to break the ice. People we know that they are very much shy in talking, so we need to break the ice, and I think we should make the initiative. And second, just to hold on, please. And just to find out why the simple act of self pleasure has become an act of anxiety and guilt among youth and middle-aged men. So many of the patients, irrespective of their age, I can say 20 to 30% of the patients are very much concerned about their masturbatory habits and the future, what they have because of masturbation. So because of all these things, we need to talk more about masturbation and freely, and we choose whatever language the patient wants. And that is, I think, very important. How do we define it? Masturbation is a sexual stimulation of one's own genitals for sexual arousal or pleasure, usually to the point of orgasm. Masturbation is the first sexual act experienced by most males and females, which may continue to do in adulthood or throughout their lives. So many people are very much comfortable with masturbation and they actually avoid sexual intercourse and indulge in masturbatory practices. And in young children, masturbation, if done in limits, is a part of child's exploration of his or her body. So this is also very, very much necessary, because we have seen that people who do not masturbate can develop some sexual problems. In young people, we can find that it is difficult to accept the situation, the truth, and the normal variation related to masturbation. They are not able to digest what masturbatory habits in whatever frequency changes their body, and what is a normal variation. So because of all these things, they develop a certain amount of fear, not related to masturbation, but because of the side effect and because of their urge of not controlling it. There is a certain amount of guilt after masturbating. There is anxiety of not masturbating. There is an anxiety of controlling masturbation also, and there is an anxiety of not able to control masturbation for the next time also. There are psychosomatic complaints that we have seen, that we can say that in Southeast Asian countries especially, there are psychosomatic complaints, such as they have this misconception that, sir, I'm suffering from hair fall, there is darkness, dark pigmentation below my eyelids, and I'm not able to gain weight, I'm not able to focus on things, I have a lot of cramps, I can feel the weakness in my knees. So these are some of the psychosomatic complaints which the patient suffers from. Then there is sexual weakness. There is an anticipation of sexual weakness, we can say, and certainly there is a small amount of depression also. Now, why do people masturbate? If it is so much controversial, if it is so much abused and used, then why do people masturbate? First, they feel good. Second, they relieve the sexual tension. Third, they get relief from stress. nowadays we can see that the people are having very much poor coping mechanisms. So masturbation is the only thing which they can do to relieve stress. To sleep, this is one of the most common side effects of most common behavioral side effect of masturbation addiction or masturbation compulsion, we can say. Sorry. It is a safer sexual act. Definitely, it saves from pregnancy and STDs, and at the same time, it can gratify you sexually. Sometimes to give semen sample in fertility clinics, and sometimes for sperm donation. It might be described by the therapist also that it is a good exercise in some patients as a part of therapy to deal with certain sexual problems. Now, when can we call it as a compulsion? That it is a compulsive sexual behavior. It has turned into a compulsive sexual behavior. Whenever a patient prefers masturbating over socializing, then it is called as compulsion. First thing a patient do whenever there is a free time, so he masturbates or she masturbates and then does other job. Cannot stop thinking about masturbation. Whenever they are free, the first thing they think about is masturbation. And whenever they are getting free, about to get free from work, the first thing they do is masturbation. Cannot sleep without masturbating. As I told you that this is a very common behavioral side effect of masturbation, and it starts affecting their everyday habits and chores. Then we can say that there is a compulsive behavior. Exact frequency of masturbation has not been stated yet, and it is not believed also if someone has mentioned, and it is very much subjective. There can be 4 stages of masturbation. First, finding material. I'll get back to you after some time. I'll get back on this topic. And ejaculation, then there is ejaculation, then there is satisfaction, and then there is a certain amount of regret. Now, finding material. So what is happening is usually this masturbation habit is related to porn watching also. It is connected to porn watching also. And the amount of porn which we have consumed in few years, it has actually increased our threshold. So every time we want to masturbate, we actually need a good material, a hardcore material, and that should be different from the last one. Then only we can get aroused for masturbation. So there are some common misconceptions about masturbation. There are myths which are believed blindly. First, stop masturbation before marriage. Many patients come within a time span of 3 to 6 months of getting married. Sir, I want to stop masturbation. I want to recover from my sexual weakness, so that after I get married, I am able to actually perform. Okay. Second is masturbation causes sexual issues. No, it is not true. It reduces size of the penis. This is also a myth. It is responsible for infertility. No. You'll enjoy sex less. This could be considered because many times, as I told earlier also, many times we have seen that patients are actually very much comfortable in masturbating than indulging in sexual activity. So they avoid sex and they masturbate. Right. Next we have, it makes semen thin. No, it is not true. It causes hair loss. It causes generalized weakness. It curves your penis. No, there are certain amount of deformity or a variation in shape and sizes of the penis. So it is not because of masturbation. It causes prostate cancer. This is also not true, because many times many urologists, they advise elderly patients that we should we should actually masturbate if we are not indulging in sexual activity, and it actually saves us from prostate cancer. Then there are other sex related myths which can be discussed. For example, good sex leads to a wild orgasm and it should always happen. No, this is not true. A male should be ready for sex all the time and should satisfy his partner in every act. This is also not possible in every sexual encounter. For a successful intercourse, all men should have bigger penis size. This is one of the biggest myth and biggest obsession of patients coming to a sex clinic. In every intercourse, semen should come out. No, there are anejaculatory orgasms also. Shape of the penis is not curved; it should be straight. This is also very much obsessed topic that, sir, we have seen in porn that there is always a straight penis and it should be longer. And I have masturbated for long enough so that because of this, my penis has taken a curvature or it has bent permanently towards one side. Okay, so this is a very common myth which we can see in male patients especially. Now, what are the sources of information? So first is the Google and the YouTube. Many times people come that, sir, we have seen on Google, we have read on Google or seen on YouTube. So I actually tried to check that material also, and to my surprise, majority of the material is very much true and scientifically correct also. But it is a problem of perception of patients, general population, that they grasp only the negative points from that material. So source of information could be correct, but the perception could be wrong. Then friends, if you are young, you do not know about sex, sexual intercourse, masturbation, then your friends are also at the same level. Family could be, not a good place to start discussion. Then self-proclaimed sex gurus, they are actually self-proclaimed sex gurus and quacks and hakims, babas and vets. They are actually just they just want to mint money from you, and there is a common practice of validating each and everything that yes, you are having this problem and this is this is a major issue, this is a disease, and I think you should get treatment, and they charge a lot of money for it. Okay, so never try to ask anything from such people. And last but not the least, no offense, please, any professional who is an expert but is from another field, so that I think that they are also not a good source of information, because many people commit mistakes in other fields, for example other branches of medical sciences. Then there are certain health benefits of masturbation also. For example, it is normal, healthy and safe. It helps you sleep better. It boosts your mood, as I mentioned earlier, that there is a lot of poor coping mechanism, poor coping skills in people, so they actually try to masturbate and then they find relaxation in that practice. It relieves cramps in certain females. Masturbation can be considered a problem. When it can be considered a problem? First, when it inhibits sexual activity with the partner. If you are actually avoiding sexual intercourse and masturbating, then this could be a problem. If it is done in public, definitely. Or it causes significant distress to a person. After each and every sexual masturbation, there is a distress. Then I think that has led to a problem. So try to limit it or try to avoid it. It can cause distress if done compulsively or interferes with daily activities. We have discussed that earlier. Masturbation can improve your sexual health. This is very much true. Helps in exploring your own body and determining what is erotically pleasing to you, and you can share this with your partner. Actually, when you want to explore your body more, masturbation helps, and this message can be conveyed to your partner also, so that you can have a good sexual communication. It helps in discovering new techniques for more satisfying sexual relationship. And masturbation doesn't cause any harm, either physically or mentally, even if you do it often. But sometimes it could be misinterpreted because of certain symptoms. For example, if you are doing in short time span, masturbation can cause a lot of soreness in your genital organs, which can be misinterpreted as sexual illness. Now, there are certain do's and don'ts which I want to discuss for the doctors if a patient is coming to you. First of all, consider each complaint as a matter of concern. Do not ignore such complaints. Always agree to what the patient complains. Do not try to correct it on the first hand. After the whole session, try to explain the patient about the actual situation, myths and facts. But first listen and then try to explain. On the very first session, try to give them a basic medication or therapy, which actually helps because they find some physical changes in their body and they get very much relaxed. So basic medications or therapy can be started, and always try to educate a patient for a little more than required, so that they are prepared for other challenges also. Any questions?
Thank you, Dr. Ahmed. A very nice presentation. You covered
ma'am.
all the things. Very nice. So, meanwhile, we will start the presentation start with the discussion with the Dr. Mitali till we are getting the questions. I think till now we have not received any question, not also in the YouTube also we have not received any question. So, may I request Sahiti? Sahiti, please introduce Dr. Mitali.
Yes, ma'am.
Yeah.
It's my privilege to introduce Dr. Mitali Srivastav, ma'am. Ma'am has done MBBS, MD Biochemistry, and ma'am has found the stark vacuum that exists in the field of women's wellness, especially in sexual medicine. Ma'am has pursued Dr. Mahinder Vatsa's correspondence course in 2017 to gain more knowledge about sexual health. Ma'am has went to complete her European Society for Sexual Medicine school training at Hungary 2022. Ma'am has always held a passion for women's wellness, who relentlessly works to create awareness about sexual health in women and couples. She is currently pursuing the fellowship in psychosexual medicine, JSS University, Mysore, and practices at Sheetal Women's Hospital, Ahmedabad. She hopes to one day to be part of the fourth sexual
Foreigners in
wellness.
women's sexual wellness. Yeah. So, thank you, Sahiti. A warm welcome, dear Dr. Mitali, and thank you for accepting the invitation. Though we and Mitali have met only for, I think, a fraction of seconds in the conference,
Yes.
but that is I connected with her, this Dr. Mitali, at that time only. So I thought at that time only I will definitely invite her in one of my webinars. So friends,
Thank you
today
so much,
Dr.
ma'am.
Mitali, most welcome, dear. So today Dr. Mitali is going to discuss with us related to the female sexual dysfunction. Friends, as we know that lot of patients are coming to us that due to sexual dysfunction, that divorce is going on. So we always know because what is the reality is that divorce is actually starts in the bedrooms and in the courtroom. So lot of patients are coming, they are having some hesitancy, they can't discuss with their family, with the friends. So there are a lot of questions in everyone's mind. So once the doctors or the counselors who start the practice for this sexology, there are a lot of questions among them also. So, Dr. Mitali, my first question to you, that what the precautions the counselors and doctors have to be used while they are dealing with the patients with the female sexual dysfunction.
Yeah, I'll just say, Nahinda, thank you so much for having me here, and it is so nice to collaborate with Dr. Atmik. And I see some people from the conference. It's really good, and I think our topic is important because we have more and more women coming to us now, and I'll just get right into it with the precautions that we as counselors, doctors, or therapists that we need to take uh, from this side of the line. The thing is, as a woman counselor, as a lady doctor, it is very easy to understand a woman who's in front of me, who's married, who's maybe has a child. And the precautions that we need to take is easy to understand because I myself am married. I myself know a lot of women in my own circle who have children who are married. The thing is, their sexual issues are not alone. It overlaps with a lot of family issues, relationship issues, past history, abuse, and just an in general common fear of sex in general. So that is one thing. So what we can do to help them is make them aware that there is this person, me, I'm sitting here, I'm here to help you. When it comes to this taboo topic, I'm here to help you. I can listen to you and I can create that safe space for you. So the first thing that we need to do is be very non-judgmental about it and see to it that they don't feel pity from us. They can feel compassion, they can feel empathy. We cannot pity them. And when they come to us with their stories, we have to be very discreet. That is another important thing. We can discuss it later, but we must remember what to say in front of whom. In the first visit, often they come with family, often they come with the
True.
husband. So we cannot extract the entire history from them in front of the husband. There are a lot of things that she might tell us in a one-on-one interview. So these are certain things that we need to watch out for. Another thing would be to ask about their privacy, what sort of privacy they're afforded at home. we can ask them about their relationship status. A woman who comes alone, trust me, we are all very beautiful, and nobody knows whether we look in our 30s, 40s, 50s. The way women carry themselves, you never know. So it's always better to just politely, very professionally ask them, what sort of relationship are you in? Are you in a relationship, like that? Do you have any other partners, in a very pleasant and professional way, without sounding judgmental? That is very important, because they could be a divorcee, they could be in an open relationship, they could be in a polyamorous relationship, depends. So we have to convince them that we are not being judgmental at all. We are actually not being judgmental. With the amount of awareness we have, we end up not being judgmental at all, actually. So that is one good thing. Then
Yeah. Hmm.
we have to make them comfortable. That's
Yes.
very important.
Yeah, very true. May I request Sahiti, please make it a spotlight. So, very true, Dr. Mitali. As you have nicely covered, yes, once the patient is coming to us, yes, we have to take them in the confidence. And these days, we are seeing lot of patients with the polygamy, and the girls themselves disclose, yes, we are not enjoying, we are having some problem with this partner, with the earlier partner, I am more comfortable. So yes, this is also very, very important. We have to take the patient in the confidence. So as you have already mentioned, so my next question to you, what's the role of the family? Do you think the family also plays a very important role, or how can we convince the family members also?
I think yes, the family plays a very important role in causing sexual dysfunction, because sexual dysfunction actually sits between the couple. It is related to the couple, but a lot of times, when the couple comes to us, or when a woman comes to a sex therapist in India, it is at the point of infertility. By then, the entire family is involved. By then, बच्चा क्यों नहीं हो रहा है? Why is there no child?
True.
Why, when are you having a second child? Why are you not having a child? Questions like those. So these questions are not from the couple. Nobody has asked them whether they even want a child. And these questions, this sort of pressure actually comes from the upper generation or the surrounding family. This is one thing. The second thing would be, when you bring the family into your counseling room, you cannot talk about STDs, sexually transmitted diseases. You cannot talk about infertility, because when you talk about infertility, somebody or the other is going to assume that you are blaming the woman. Something is wrong with her, or you are blaming the man in a case of impotency, for example. And then it's going to become a big blame game, and it's going to break the family dynamics. Let's just not go there. So what we can do is politely get the family out of the counseling room and assess how comfortable the woman is, assess how comfortable the man is, kind of read between the lines, so we know if they're hiding something, and suggest a one-on-one where we understand what the woman is trying to tell us, where we understand what the man is trying to tell us. One-on-one sessions help a lot. As for the family, we can seriously tell them that it is very open if we have just the patient with us, and then we go from one-on-one, we go to the couple, and then we talk to the couple. Do you want me to be the villain? What do you want me to tell your family? I can take that burden, I can do that for you. And that makes a person, the woman, whoever has the problem, it makes them so much more comfortable, because now the choice of telling the family is in the hands of the couple, and that, trust me, that really builds a very good rapport with the patient. Other than that, we can counsel the family in cases of infertility, in cases of other types of sexual dysfunction where the relationship is affected. We can counsel them to be more supportive, to remove the pressure, whatever it is that you have to get along with your husband. And we can teach them the dynamics of a couple, how not to disturb it, how to best support it. Let the husband work in the kitchen so the woman feels supported, and then that improves their relationship. This is just an example. I'm just bringing it from my own experience with patients.
That's great. That's great. Thank you. Thank you, dear Mitali, for simplifying this in such a easy manner so everyone can get to some take-home points. So now my question, as today we are discussing for the female sexual dysfunction. So can you advise for the doctors that some tips while dealing with the patients with the female sexual dysfunction? And later on, I want to ask you the out of the box the question, what advice you are giving to us female doctors while examining the male patients?
Okay. Yes, first
Yeah,
we'll talk about some
yeah,
extra tips that that will help us as
yeah,
doctors when we are
yeah,
dealing with female patients. The
yeah.
first thing that I'll tell you is something that I actually learned from one of my colleagues at ESSM. She was a gynec, and she told this from her experience, and then I started practicing it in my hospital. So I work in a women's hospital as an assistant consultant, and there's a gynec surgeon who's there, who's my boss and my husband. So we work there, and what I've seen is a lot of women come to us, and they need to undergo a transvaginal ultrasound. Now, as you know, a TVS is unpleasant and uncomfortable. Whether it is for a woman who's looking for ovulation studies, or whether it is for somebody who's in the early stages of pregnancy, it can feel like a violation. Because of course it feels like a violation because it's a plastic probe and that's going inside your body. It's so unpleasant. So what we can do is we can actually ask the patient, are you comfortable with me putting this inside your vagina, or do you want to put it inside the probe? Do you want to put the probe inside your vagina on your own? That gives them agency. It gives them a choice. So it doesn't feel like a violation. And trust me, that patient is never going to leave your clinic. They'll come back to you because that sort of comfort they are not going to get anywhere else. But it should be a common practice, because a transvaginal probe, when a woman puts it inside, there is such a lot of more there's such a lot of compliance. She's more amenable to a longer examination. She's more open to telling us about her difficulties when it comes to penetration. It can even work as therapy. I had a patient with vaginismus, and every time she would take 10 minutes, 12 minutes to insert the TVS probe. They were also planning a family, and over time I was like, you take all the time you need, and we would just talk about the penetration difficulties and all. And over time, it got to a point where they could have sex on their own at home. So that was kind of therapeutic. Obviously counseling and all was going on. Also, she could insert the probe within 7 seconds. So that was a record, and she was very happy, and I was very happy that this TVS probe worked that way. And another example I would give you is when you're talking about sexually transmitted diseases to a woman, we are non-judgmental people. We are aware people. We don't know from where she has picked up a particular type of STD. For example, she has a pelvic inflammatory disease and the cause looks to be chlamydia. Okay. So now we cannot tell her that, it's a sexually transmitted disease. We cannot tell her that it is your husband might have it. We can just especially avoid it in front of the family, avoid discussing this beyond the husband and wife. And even when we are talking with the husband and wife, we don't have to explicitly state that it is a sexually transmitted disease you picked up from one, from somewhere else. You can't do that. So be very careful when you're talking about STDs, especially when it comes to women. We are not responsible for the making and breaking of marriages, right? We are simply there to help them with their sexual issues, right? So that is one thing. Another thing would be, watch for abuse. Be very careful. Just watch for abuse. Watch for signs of abuse. See if the woman might be undergoing emotional or physical abuse or sexual abuse, and accordingly have referrals ready. Know what to do in your own state or country. Yeah.
Yeah, very true. So thank you for clarifying all this. Now, Mitali, please will you share some tips while examining the male patients with the sexual dysfunction? These days, lot of patients are coming. Yes, madam, you are dealing with the sexual health patients. So usually the common query, I want that everybody can answer and can participate now, because what the questions I was thinking to ask Dr. Mitali have already covered, especially for the female doctors, when the lot of patients are coming with the male sexual dysfunction. And sometimes the most common query, Dr. Mitali, what I'm seeing, madam, my penis size is small, my penis girth is less. So without examining how you're advising something. So what's your opinion? How you deal with these kind of patients?
Actually, because I'm in Ahmedabad, we have very few lady sexologists. Majority of my patients are female, but sometimes they come in a couple. And when they come in a couple, obviously they are comfortable. By then we
Yeah.
have built a rapport. They let me examine. Another
Hmm.
advantage is that I have a male doctor with me who can examine. And we can do it together. He can examine and he can tell me if sometimes there's a patient who wants counseling who has come to me because he has heard from somewhere that I'm a sexologist and he can come to me, but the patient is not very comfortable because of my gender, and I can assess that that there are some people who are very shy, they've come from outside, they're not very comfortable with the language, they're just not comfortable. I refer them to a male sexologist. And sometimes if it looks like, because once we examine, we can the small penis and all these things we can counsel easily. It's very visible that they have a normal penis. It's just a normal average penis, nothing to do with it. But sometimes if we see that, upon examination, we do find some issues with the penis, or it looks like, phimosis or something else, then I refer them to a urologist. But majority of these patients, they are okay because, I think it's because we make them comfortable. The other thing would be, I think personally speaking, that I have a male doctor with me. That helps a lot.
Good practice is beneficial in these cases. Yes. So thank you, dear Mitali, for enlightening everyone. So may I request Saiti, till we are receiving the question, please show the certificate of appreciation for Dr. Atmik and Dr. Mitali.
Okay, ma'am.
Dr. Atmik, this is a small token of appreciation from our side. The
Thank you, ma'am.
certificate of most welcome. The certificate of
Thank you.
appreciation for distinguishing, for contributing as a distinguished speaker for 24th October 2024. I will send you the soft copy. I will send you. Yeah. Now the certificate of Dr. Mitali, please.
Thank you, ma'am. Thank you.
Yeah. This is certificate of appreciation presented to Dr. Mitali Srivastav for contributing as a distinguished speaker for 24th October 2024. So yeah, please stop sharing. Yeah. So friends, now we are open for the discussion. If any questions anyone is having, you are free to ask. You can unmute and ask the question. Our dignitaries are with us. Yeah, good to see you, Dr. Sadiq Khan. Renu madam has joined all the way from Kanpur. Dr. Samuel Ajapur from Africa. How are you, Dr. Sadiq? And Dr. Munde is from Pune. There are so many friends have joined. Yeah. So yeah, Aparna is also from Pune. Yeah, thank you for joining, Aparna. So if any questions, you can ask. In the YouTube also, I'm not seeing any questions. No, till now there are no questions. Yeah. Dr. Hartman, you want to give any expert comments as you are here and you are the stalwart in this field?
No, I think the speakers have done a fabulous job. It's
Yeah.
been a delight to be here to listen and to hear what they have to say. I have great respect for both of them. So
Thank
yes.
you. Thank you for joining. Yeah. So I think with
Can I add something? I'm Dr.
Yes.
Wadia from Delhi.
Yes, Dr. Wadia. Welcome. Yeah.
Thank you.
Yeah.
Mithali, you spoke very well, of course, Apnik also, but my comment was more on you. One thing which I really find very helpful in these cases is that when I counsel a couple,
Yeah.
I always make it a point to say how we go about it right in the beginning. I mean, the kind of structured counseling we have, we always
Yeah.
apprise them, and that really helps. So one of the ways that I do it is, like I would say, for sex problems, the whether the problem is with the man or the woman, the
Yeah.
suffering is equal. So man
True.
is a half patient, woman is a half patient, and for me, you are one patient. But in case of relationship counseling, like Mithali, you said you got to give them a safe place. That is something which is very, very important. So I always make it a point to tell them that in relationship, my loyalty is neither to the man nor to the woman. It is basically to the relationship. And
Great.
you both will be, I'll be talking to you both one on one. and anything which you find is detrimental to the relationship, but you want to share with me, you must share at that point in time. And I just tell them that whatever the man says, if it is detrimental to the relationship, will not be told to the woman, and the other way around. That gives them tremendous amount of confidence, and then they come clean with whatever they want to say without giving a second thought. So I have found that this practice really works well, and one can incorporate that in the counseling of couples. So that is just one comment I wanted to add. Another thing which I wanted to ask Atmik Jan was how often do you see cases of compulsive masturbation amongst men and women? I don't know whether you're dealing with the women cases also. How often do you get such cases?
Sir, almost daily I get compulsive masturbatory behavior cases, especially in men. Means more than 90% cases are males, and that too of a certain age, like
Okay.
25 to 28 years. Because at that time they have the maximum urge of sexual intercourse, and they are about to get married, or they are dealing with some stressors. So that is the age where I get compulsive masturbation. And sometimes they are coming just before their marriage, sir, that I want to join a de-addiction program or something like that, so that I can have a good sex life after marriage. And not exactly females, because females usually do not open up very much. And if they are coming with their husbands only. So I have
Okay.
found very less cases of female compulsive masturbation.
Atmik with
Okay.
me, because I am practicing in Pune, Korega Park. With this, I am getting a lot of females which are coming with this complaint, and females are themselves telling, ma'am, I was masturbating once in a week or twice in a week. Now, from last few months, I am masturbating daily, four times. Is
Yeah.
it going to hamper my fertility? So these days, I am seeing a lot of patients. Yes, males of course are coming, but females also a tremendous increase in
Yes,
the
yes,
number.
ma'am.
Yeah,
True,
yeah,
true.
So
yeah.
how do you go about these cases, madam?
Yeah, I will do the proper counseling and explain them. The self-masturbation is not. Yes, the some patients who are using the sex toys, we have to explain them because some patients who are coming to me with the repeated masturbation, they are using the some sex toys and having some infection. So they are not having the basic education about how to clean, how to use the sex toys. They purchase the sex toy and place in the one box only. There is Yesterday only I've seen that three girls have come. They are the flatmates, and they all the three are using only the one sex toy. Only cleaning with the vaginal wash. The vaginal wash, what they are using, they are cleaning with that. And all of them are complaining me that, ma'am, earlier one girl has suffered from the UTI. Now another is suffering from the vaginal infection. Means yesterday the scenario was like that. All the three are having the infection and came to me. So I think proper counseling and giving the proper knowledge is must.
Okay, great.
So
Thanks so much.
yeah. Thank you, Dr.
Thank
Vijay,
you,
for
sir.
joining.
Thank you.
Yeah. So there is one question from a dear friend, Dr. Mehak. Dr. Mehak is asking, what all medical conditions should be ruled out? Dr. Mitali, the question is for you.
Yes, ma'am. I think the medical conditions that need to be ruled out would include specific to the genital region, skin disorders like, lichen planus, then leukoplakia, anything that is going to aggravate bleeding, pain, burning. Then there's something called as genitourinary syndrome of menopause. These are certain things that we need to be careful of when we are examining the genitalia. Other than that, obviously, any pre-existing comorbidities, because any sort of, for example, disc prolapse is there, a lower backache, and then any sort of antidepressants that the patient might be on, any sort of underlying depressive disorders, any sort of psychiatric disorders. I'm not a psychiatrist, but I'm sure they would know much, much better. They definitely, sexual dysfunction needs an evaluation to assess for underlying psychiatric disorders as well. It is always good to have a referral doctor, I always have a doctor, a really, really nice psychiatrist who helps me out with these patients. It helps so much, because then the patient gets that much more support. And other than that, I think, ma'am, diabetes and hypertension, basic comorbidities, basic findings in women, middle-aged and elderly women, and even women of, early 30s, post-marital. For example, lower backache is there, then fatigue and tiredness, the common issues like that, ma'am. Yes.
Yeah, very true, very true. So thank you, dear Mitali, and thank you, Dr. Atmik. And thank you, my dear friends who have all joined across the geography. With this, we will wind up for today. So, yes, we will. There is one more question last we can take from Dr. Mehak only. Mehak, write the questions early, quickly. We are winding off. Huh? So, can we put some light to other extreme loss of libido? So you want to know about what about this? You want the treatment or what part you are looking for, Mehak? What are you asking? Can you little elaborate? Mitali or Atik, if you want to answer that much, you can take this question. Huh.
Sir, will you take that question?
In case of low libido in females, first of all, we can actually see for genital examination if it is possible, see for dyspareunia and vaginismus, because these are some of the most common and severe causes. And if this is the case, then actually they are reversible. So it is quite not very easy. I should not say very easy, but actually these are reversible causes. So we should not spend much time in making the diagnosis or take much time. We should just start the treatment. Other causes could be, as ma'am mentioned, there could be other causes like less foreplay. There could be other causes like a trauma. There could be domestic violence. There could be a less understanding in relationship. There could be straightaway penetration, which the female doesn't like, and the male just tries to avoid a proper foreplay and tries to doesn't try to actually stimulate or make his wife aroused. So these are some of the causes of low libido. Then we can rule out some medical conditions also. There could be a history of childhood sexual abuse also that you should ask for after building a good rapport with the patient. So these are some of the causes of extreme low libido, which can be
Yeah.
treated and are reversible actually. Try to suggest some lubricants, try to suggest some anti-anxiety pills or antidepressants could be given to such females. Educate the male patient as well, because they are actually not one who are responsible, but they can actually ease out the situation always. And they should not force for intercourse also, for their pleasure or for baby planning also.
Yes, very true. Mehak, here I want to add, yes, sometimes the patient may be suffering from some chronic illness. That also sometimes causes the loss of libido. I have seen some patients who are suffering from the treatment of the tuberculosis. One patient couple has come to me for the secondary infertility. Of course, the tuberculosis is the reason, and the couple has a complaint. Yes, the madam, my wife has not totally lost the interest. Sometimes some long-term medication has gone. That is also, and of course, in the perimenopausal ladies, we know, yes, the loss of estrogen also causes the estrogen and testosterone hormone that all decreases. That also causes the loss of libido. And some patients, a very important point I want to highlight is the smoking. Lot of patients are coming to us. Yes, there is lot of smoking and some drug abuses that are also reported with some side effects for this loss of libido. I think I can take one session on that. Yesterday I've taken one session. Yes, we can plan one session on that also. So thank you, Mehak, for asking such nice questions. Good to see you, Kiran Madam. Kiran Madam has joined all the way from the Faridabad. Kiran Madam, good evening.
Good evening, madam.
So,
Good evening.
yeah,
Good
how are
evening.
you, ma'am?
Fine, fine. Nice to
Yeah.
hear the interesting topics.
Yeah.
Yeah.
Thank you, madam. Thank you. Thank you. So, friends, with this, we will wind up. And thank you, everyone, for joining. Now, this is our the great festival, the Diwali festival is coming. So next week there will be no webinar, and after that on the 5th and 6th I am coming with the 2 webinars. I will post the plan tomorrow or day after tomorrow. So happy Diwali to everyone. With this we will wind off. Yeah. Good night.
Happy Diwali. Happy
Happy
Diwali.
Diwali, ma'am. Thank you so
Happy
much.
Happy Diwali.
Most
Thank you
welcome.
for
Thank
having
you.
us.